Well, hello and welcome back to APHA's 15 on COVID-19 series. I'm your host, Dan Zlott, Vice President of Education here at APHA. Today we're going to be talking about anticoagulation. We have gotten a lot of questions about anticoagulation. Does COVID-19 increase risk of bleeding? Does it increase risk of clotting? So today we'll take a deeper look at all of that. Before we get started, just a quick note of apology to everybody. This episode was originally intended to be released on May 11th, Monday, May 11th. However, I got word from a friend of mine who works with one of these teams that there was an update to one of the articles we'll be discussing in the works, and we wanted to wait for that update before we publish the episode. So do please accept our apologies for the delay. Hopefully the updated information is worth it. So without further ado, let's go ahead and jump in. As usual, I have nothing to disclose. Here are your learning objectives for today's activity. All right, so as we get into this, it turns out that there's not so much of a bleeding risk with COVID-19 disease, although that has been described, but there's more and more evidence that COVID-19 may induce a hypercoagulable state. So what are we seeing? Well, in general with COVID-19, what we know is that particularly in patients with moderate and especially in patients with severe disease, you see increased D-dimer and increased fibrinogen levels. Aside from just clotting, those are sort of just general parameters. Those are generally, inflammatory markers, kind of non-specific inflammatory markers. So we see that in the general population. And then what we're also seeing then, people have started to look at very specific clotting assessments. And so there's a decreased clot formation time in patients with COVID-19, as well as an increased maximum clot firmness. So the INTEM, XTEM, FIBTEM, all that stuff, that's for the anticoagulation geeks out there. Those are just different tests that are run to assess different parts of the clotting cascade, intrinsic factors, extrinsic factors, etc. So we won't go into that just for the sake of time, but that information is there for you in case you'd like it. Now, most of the data, especially about the clot formation time and the maximum clot formation firmness, does come from patients with severe disease. So in general, we're talking about the sicker end of the spectrum. So we don't have quite as much data on patients who are, have maybe mild or moderate disease. Now, what's interesting about all of this is that we really don't entirely understand the etiology of this hypercoagulability. There's a lot of speculation, and it is just that, speculation, so I'd consider this hypothesis at this point, that it's really due to thromboinflammation. So there's a close link between inflammation and the tendency to clot, especially when you start to see microvascular involvement. And so that's what we're seeing on some of these postmortems or these autopsy reports. So when they look at the specimens, they're seeing some disruption of the microvasculature, and they're seeing significant inflammatory changes. And then they're also seeing microvascular thromboses, so little teeny tiny blood clots in all of those arterioles and small blood vessels. And so when you get this sort of distributed clot or tendency to clot, that they think is maybe what's causing this hypercoagulability. So the next question is there any significant clinical evidence? So we've got some postmortem data. Is there additional clinical evidence? And the answer is yes, there is. So there appears to be an increased incidence of venous thromboembolism in COVID-19 patients. And this is particularly true in patients with severe disease who land in the ICU. So some groups are reporting VTE incidence rates as high as 27% in patients who are already on prophylactic doses of anticoagulants with low molecular weight heparins. And just for reference, a standard failure rate in a patient who's on VTE prophylaxis with low molecular weight heparins in the ICU is around 7 to 8%. So that's somewhere between 3.5 to 4 times as high as you might expect. So it does appear that there's a little bit of a signal there. All right, now that we've kind of looked at the, not exactly preclinical, but pre-observational data, let's get into some of the literature that's comparing groups who are anticoagulated to those who are not. So the first study we'll look at is a retrospective case series in about 450 patients who had severe COVID-19 disease from a single institution in China from January 1st to February 13th, 2020. So relatively early on in the COVID-19 experience. This study did have some formal exclusion criteria. So if you had a bleeding diathesis at baseline, you were excluded. If your hospital stay was less than 7 days, you were excluded. If there was no data available about your coagulation parameters, PT-INR, clotting times, all that good stuff, or if they didn't have a good history of what anticoagulation medications you were on, you were excluded. And then finally, if you were less than 18 years old, you were also excluded. Patients are in the study. So the outcomes, so this was an observational study, so there really were no predefined outcomes here. However, the authors did state that the main aim of the study was to validate the usefulness of the sepsis-induced coagulopathy score, as well as other coagulation parameters to identify patients who could benefit from anticoagulation. So we don't really have a specific set of things that they're looking at, and we'll see at the end that's a potential limitation of the study. So what were the results? So first off, they screened just over 1,700 patients, almost 1,800 patients to get to their final 449. 1,260 patients didn't meet the definition of severe COVID-19 disease. So they had either mild or moderate disease, not severe, and so they were excluded. And then 76 patients met one of the formal exclusion criteria that we discussed on the previous slide. So they were excluded. So let's continue on with the results, and we'll start with a further examination of who the patients were in this study. You see a slight male predominance, 67% male, and that's not all that uncommon in patients with severe disease, so nothing too unusual there. The average age was 65.1, but that's smack dab in the middle of what we'd come to expect in patients, particularly those with severe disease. 60% of patients had a comorbidity, and the particular comorbidities and the incidence of those comorbidities is listed there for you. Again, about what we'd expect. So turns out that out of the 450, about 100 patients received anticoagulation in the form of either heparin or low molecular weight heparin, and in particular, enoxaparin. So 94 patients received enoxaparin, 40 to 60 milligrams a day. 5 patients received unfractionated heparin, and those were the only 2 anticoagulants that were used. Now, a quick note on dosing. The authors did not state whether they considered this to be a treatment dose or a prophylactic dose. It's somewhere in between. It's a little bit aggressive, especially on the higher end for a prophylactic dose. It's a little bit light for a treatment dose. So not quite sure what to make of that, but it is what it is there. Additionally, 97 patients met sepsis-induced coagulopathy criteria, and they considered that an SIC score of greater than or equal to 4. And so the SIC scores were based on platelet counts, PT-INR, and SOFA scores, sequential organ failure assessment scores. So if you want to know more about SIC criteria, there's a bunch of other literature out there that examines it. We won't spend too much time on it here today. So continuing on with the results from this study, there were 134 patients who had died at the end of the study period, about 30% of the patients in the study, and there was no difference in 28-day mortality between patients who received anticoagulation and those who didn't, about 30% in each category, and you can see the p-value there, very statistically insignificant. However, when they did a look at some subgroups, they found some interesting things. In patients with an SIC score, again, sepsis-induced coagulation score greater than or equal to 4, if you received anticoagulation, that was associated with a lower 28-day mortality rate as compared to those who did not receive anticoagulation. And the rate is there for you, 40% versus 64.2%, and the p-value there was statistically significant. Likewise, in patients with elevated D-dimers, so the cutoff there was 3 micrograms per mil, which is, at least according to their lab, 6 times the upper limit of normal. Anticoagulation was associated, again, with a lower 28-day mortality, and that rate was 32.8% as compared to 52.4% in patients who did not receive anticoagulation. And again, the p-value there, 0.017, statistically significant. All right, so what were some of the limitations of this study? Well, the first, of course, is that this was a retrospective case series, no randomization, no control group, etc. The endpoints in the study were not predefined, so it was observational. So what they found is you can say there's a correlation and potentially something more. However, it's not fair to say that there's definite benefit based on what we saw in this trial. In addition, the cutoffs for the SIC score and the D-dimer levels weren't identified prospectively. So there's always the possibility that they may have just done a bunch of statistical tests and chosen the numbers that were statistically significant. So it's sort of like, I like to think of it as darts. You know, if you have a dartboard up on the wall and you throw darts on it, that's sort of the equivalent of predefining your endpoint. On the other hand, the other approach is throw the dart first and see where it lands, and then draw the dartboard around wherever the dart hits. It's very easy to hit bullseyes, or in the case of a study, it's very easy to achieve statistical significance when you take that approach. And you, not that that's what they did, but there's always that possibility when you don't predefine your endpoints. So one potential weakness there as well. The data from this, so that's all of that is really to say that this is hypothesis generating only. It needs prospective validation to confirm that there is in fact a benefit to anticoagulation, and that the cutoffs that they used for both the SIC and the D-dimer levels are the appropriate cutoffs to use. So until then, this is just for the basis of generating the next trial. We had a relatively small N in this trial, both overall, there was 450 patients, and then in terms of the number of patients who actually received anticoagulation, there were only about 100, and an even smaller number who met the SIC or D-dimer cutoff criteria. So not a lot of robustness to the data, at least based on what we have. Additionally, there was no discussion of bleeding rates. So anytime we talk about anticoagulation, we want to talk about the benefits, but we also want to assess the risks. So we're only really getting half of the discussion that we'd like to see. And finally, there was no discussion of other COVID-19 directed therapies. And of course, that has a significant impact, or at least the potential to have a significant impact on mortality. So it would be nice to see some additional data about that in the trial discussion. All right, now let's go ahead and move on to our next study. So this was an observational cohort study in 2,700 hospitalized patients with COVID-19 within a single health system between March 14th and April 11th. So this was actually a health system coming out of New York. This was the one that we were waiting on for updates. So let's dive into this in a little bit deeper. There were no formal inclusion-exclusion criteria set for this study. And what they did is they used a Cox proportional hazard model to evaluate treatment dose anticoagulation, the effect of that on in-hospital mortality. So what they're trying to do is control for different variables, and we'll see what some of those variables are using a statistical Cox proportional hazards model. So what they looked at was anticoagulation of any form, whether it was oral, sub-Q, or IV, and a variety of different drugs. They didn't actually specify which medications and how many patients were on which specific anticoagulant. So we don't really have a lot of detail there. The statistical adjustments that I mentioned earlier were made for age, sex, ethnicity, BMI, hypertension, heart failure, AFib, type 2 diabetes, and anticoag use prior to hospital admission. So these are all things that we think may have an impact on COVID-19 mortality rates, and so that's why they're trying to adjust for those things. So they're defining in advance what they're going to adjust for. Now, let's talk quickly about the results. So there were, out of the 2,700 patients who were in the study, just under 30% received anticoagulation, 786, while they were in the hospital. There was a median length of stay for the hospital of 5 days, and the interquartile range there is there for you, 3 to 8 days. The median time from hospitalization to initiation of anticoagulation was 2 days, so relatively quickly. And again, the interquartile range is between 0 and 5 days. The median duration of anticoagulation therapy was 3 days. The IQR was between 2 and 7 days there for you. All right, so now let's take a look at mortality rates in patients who were anticoagulated versus those who were not. So the in-hospital mortality rate was 22.5% in patients who received anticoagulation versus 22.8% in patients who did not. So not a lot of difference in terms of overall survival. However, it's interesting, when you look at median survival, there was a difference. They didn't report on whether it was statistically significant or not. However, the median survival in patients who received anticoagulation were 21 days, as compared to 14 days in those who did not receive anticoagulation. So that's what the image here is showing. So this is a Kaplan-Meier curve, so if you're not used to Kaplan-Meier curves, on the left side is the survival probability. 1 means that everybody's alive, 0 means that everybody's dead, and you can see that dashed line at 50%. So median survival is when either the red or the blue line hit that dashed line at the 50% mark. That's median survival. So you can see the red no anticoagulation arm hits that mark at 0.5. When you go down to the axis of days since admission, you can see that's 14. That's where it crosses. So that's where you get the 14 days median overall survival from. And then the blue line crosses that 0.5 mark just after the 20 days, so 21 days, and that's where the 21 days median survival comes from. So kind of interesting. There's you live longer, but overall not more people live. And that's a phenomenon you see occasionally in oncology in particular. We see that all the time, but it's interesting to see this in an anticoagulation study. So let's take a look now at maybe a subset. So in patients who require mechanical ventilation now, we see a really significant difference in both of these parameters. So the in-hospital mortality in patients who were anticoagulated was 29%, as compared to 62.7% in those who were not anticoagulated. Likewise, there's a pretty significant difference in median survival as well. 9 days in patients who were not anticoagulated, and 21 days in patients who were anticoagulated. So you can see the red and blue lines separate almost from the outset, stay very nicely separated all throughout. So that suggests a pretty significant advantage to anticoagulation in the subset of patients who require mechanical ventilation. So we'll talk about how to interpret this in just a second. Now, interestingly enough, they reported out that when they looked at who required mechanical ventilation, 30% of patients who received anticoagulation, 29.8%, required mechanical ventilation, as compared to only 8.1% of those who did not receive anticoagulation needing mechanical ventilation. So should we infer then that administering anticoagulation increases your risk of needing mechanical ventilation? The answer is no. This is one of the problems with observational studies. Just because there's a correlation doesn't necessarily indicate causative effects. So what's happening here most likely is that they know that patients who are intubated, who are mechanically sedated, are not moving and therefore are at risk of clots. So they're probably anticoagulating them more. It's not so much that the anticoagulation increases your risk of mechanical ventilation. So again, when you see these types of statistics coming out of observational studies, don't assume causation. Correlation is not causation. In the full multivariate analysis, this is where they're taking into account all those factors they told us about up front. The longer duration of anticoagulation was associated with a reduced risk of mortality. So the longer you were anticoagulated, the less likely you were to die in their model. So the adjusted hazard ratio was 0.86 per day of anticoagulation. And the 95% confidence interval there is 0.82 to 0.89. So since we're talking about hazard ratios, the magic number is 1. So since the 95% confidence interval does not cross 1, that is considered to be statistically significant, and the p-value confirms that that is in fact statistically significant. So they also talk about bleeding risk in the study, which is nice to know about. So 3% of patients who received anticoagulation had a bleeding event versus 2% of those who did not receive anticoagulation. So there were still bleeding events in the non-anticoagulated arm, which is kind of interesting as well. In the patients who received anticoagulation, 9 of them had bleeding events prior to starting anticoagulation. And the authors didn't go into a great amount of detail to talk about what caused that. Was it an injury? Was it an intubation-related event? We don't know. And so we also don't know if they had additional bleeding events after starting anticoagulation. That level of detail wasn't provided. So we definitely have a few unanswered questions there, but at least we do get a sense of what the incidence of bleeding was in the anticoagulated patient population. So obviously there were some limitations to this study as well. The first is that this was an observational study, no randomization, no placebo control, no control group really of any significant kind. So, still needs some prospective validation there. The cohort population really wasn't well defined for us either. There weren't specific exclusion criteria like we saw in the previous study. Additionally, they didn't really go into the discussion of comorbidities. They did attempt to control through them through statistical analysis and statistical modeling, but they don't describe them to us, so we don't know if this is representative of the general population or if there's something unusual about this population. Additionally, we don't get a lot of information about COVID-19 disease status. Clearly, that has a huge implication on mortality rates, which we were looking at as some of the outcomes that they described in the study. So without that information, again, it's challenging to make some assumptions. I mean, we obviously do know that some of the groups they were looking at were people who were on mechanical ventilation. So clearly that's by definition severe COVID-19 disease. So we've got that group, but some of the others where there was not as much of an obvious survival advantage for anticoagulation versus no anticoagulation. Again, that information might have been helpful to us, and they don't really give us a lot of detail. They also don't talk about other COVID-19 directed therapies. So what other antivirals were there? Were they giving these patients anti-inflammatories, IL-6 antagonists, especially in severe patients? So again, a lot of unanswered questions here. There were also multiple anticoagulation therapies included. And so whether or not the type of anticoagulation therapy, whether it's sub-Q low molecular weight heparins as compared to a heparin drip, as compared to the direct oral anticoagulants, we don't know, and it's impossible to tease out. We don't know what proportion of the population was on what type of anticoagulation. So another open question for us. And so we also don't know what the doses were, what was described as treatment doses in general in this population. So it wasn't just a prophylactic dose, it was treatment doses. But even within that, there are some ranges. There's different approaches, particularly with low molecular weight heparins, to what you consider a treatment dose. So again, a lot of unanswered questions. The other thing was the endpoints weren't predefined, just like in the previous study. They were looking for correlations, and so when they find them, it's hypothesis generating only. So what's the bottom line when it comes to anticoagulation and COVID-19? So data suggests that anticoagulation may play an important role in the management of patients with COVID-19. How exactly is still yet to be defined. Keep in mind we have observational data only at this point. And so it's difficult for us to draw concrete conclusions from that. That said, of course, it's always appropriate to consider anticoagulation in a patient who's sedated in an ICU, non-mobile, et cetera. So I think those standards haven't changed. The question is, do we need to be using more aggressive anticoagulation strategies in these patients? And so there's some data that's suggesting that maybe we do, but the true benefit is not really been assessed, and we don't have the answer to that question just yet. We also don't know if we should be using anticoagulation in early disease. Is there a benefit there? Same for moderate or severe. So as with so many things with COVID-19, we always have more questions than we have answers at the other side of these things. Again, do we use standard prophylactic dose? Do we use treatment doses? Again, all questions to be answered. What's the bleeding risk like? We also didn't get a good sense of that. We saw some information, but not a real deep dive into that. So we'd really like to see the overall assessment to see, is there an overall survival impact across the board with anticoagulation that would take into account the bleeding risk and potential deaths from bleeding as well. So as always, we still need more data. So that will wrap up today's 15 on COVID-19 episode. On Monday, we're going to be talking about another question we have received a ton of questions about, and that is COVID-19 antibody development and the possibility for reinfection. So we look forward to seeing you on Monday. We hope you've enjoyed the series, and we will talk to you next week. And as always, if you have questions about COVID-19, please keep them coming. covided@aphanet.org is the email address. We're checking that multiple times a day. A huge thank you to those of you who've already submitted your suggestions. We keep using these to generate future ideas for these topics, and there is just no shortage of questions that need to be answered. So we look forward to helping you answer them. And again, we hope to see you on Monday.